Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society here at ASH 2022.
Hello, my name is Stephan Stilgenbauer. I'm the medical director of the Comprehensive Cancer Center in Ulm at Ulm University, Germany, and have a long-standing research interest in CLL, clinically as well as laboratory. Pleasure to be here.
Dr. Stilgenbauer, you and your teams and some of the research has been incredibly well organized and carefully planned to answer questions for the CLL community in Germany. It's a real model, I think, of collaborative efforts across different centers in Germany and sometimes across all of Europe and the world. And I wanted to talk to you about a paper that's an oral presentation, so a paper that your colleagues think is really quite important. And it's the final analysis of the progressive multi-centered CLL2 GIVE trial of Obinutuzumab, or Gazyva, what it's called in the US, Ibrutinib and Venetoclax. So it's those three different drugs, Obinutuzumab, Ibrutinib, and Venetoclax, in untreated patients with CLL and with 17p deletion, or TP53 mutation, which puts them at high risk. So it's one of the triplets, and one of the themes that we've seen here today, or through the whole conference, has been combination therapies. There's a full session on doublets, a full session on triplets. So this GIVE combination, talk to us why you put this trial together, what you and your colleagues were thinking about, what questions we were looking to answer in this with this important trial.
Right, so thank you very much, Brian. So indeed, in Germany, we have this long-standing tradition of being a collaborative study group. We have a multi-center trial setting and do a lot of translational research based on central biobanking that we do at our lab in not only national but international, partly global trials, which allows very thorough translational clinical research in trials, find new prognostic markers, find resistance mechanisms, and develop new treatments. Now, as you said, with Ibrutinib and the next generation BTK inhibitors, Acalabrutinib and Zanubrutinib, we've seen dramatic advance in tolerability and efficacy of safety treatment. Also with Obinutuzumab plus Venetoclax, we see in that progress. Nevertheless, some subgroups, such as the subgroup with the 17p deletion and or TP53 mutation, remain problematic. They have shorter time to treatment failure. So with that trial, we aimed with a combination of the three agents to improve the depth of the response, to reduce the CLL burden as deep as we can, have a finite treatment duration, and a lasting response in that high-risk patient population.
Well, all of these are very potent drugs. This group that you study were patients, this is their frontline therapy, but they were at high risk for more difficult to treat disease. What were their safety issues? Because all of these drugs can be somewhat immunosuppressive. They can have other side effects, cardiac side effects. They can drop the blood counts. So I would worry putting all three. There was infections during the pandemic, I'm sure. So what kind of toxicities, adverse events did you see putting these three powerful drugs together?
Absolutely, very important, not only to look at efficacy, but also at tolerability of treatment. And as you say, these are very potent drugs, but they do have their side effects. Assuringly so, what we saw as a most frequent side effect was the decrease of the neutrophil count. So the white count decreased, putting patients obviously at a risk of infection. Fortunately so, on that trial, we saw a very average infection rate and no unusual infections, in particular no opportunistic infections. So that was reassuring to see.
So opportunist infections are when people are immunosuppressed and a fungus or a bacteria that normally wouldn't be pathogenic, normally wouldn't make somebody sick, makes them sick, and you didn't see any of those.
Indeed.
Yeah.
Nevertheless, another important point that you raised is, I think with all of our CLL treatments or cancer treatments, maybe in general, before you start a treatment, you should make sure that your patient is fully vaccinated, because on treatment, the response to the usual vaccines that we have available is impaired.
I have to ask you, because during the pandemic era, you must have seen some COVID infections with this treatment.
Yes, unfortunately not on that trial.
Oh, okay.
We didn't have a COVID infection on that trial, but in general, when we look at our larger trial population, we see that, and we know that unfortunately so patients living with CLL have a higher risk to get a COVID infection and have a higher risk to have a severe course of that infection.
So you said there was concerns that some of the counts were low, the white counts were low, specifically the neutrophils. Were there any other adverse events that were unexpected or in combination that were a problem? We know that ibrutinib can have some cardiac issues with it, and were there, we get some GI issues with Venetoclax, and there's tumor lysis. Did you see any of this stuff in a different way when you put all three together?
All side effects that we saw were in line with the tolerability profile that we know of these compounds. Yes, there were GI side effects, so diarrhea was a feature. Nevertheless, with that regimen, we have a 1 year fixed duration treatment for the vast majority of the patients. And obviously when you are off therapy, this is a time where side effects are very much decreased. And this is the whole aim of the thing, not to have this continuous therapy that puts you at risk for side effects over years and years and years, but to stop treatment at one point and live, if possible, perfectly normal life.
So let me ask you about that in terms of the trial design. So this was a fixed duration, 1 year, but you said most patients, but was there an option?
Indeed.
To stay on the therapies?
Right. So after 1 year of treatment, we had a response assessment, and patients who didn't have a complete response, i.e. clinically the disease wasn't gone, including imaging, and was not detectable by minimal residual disease measurement anymore, they stopped treatment. Only patients who did not have that complete response or who remained positive for minimal residual disease measurement continued ibrutinib for 36 months, but these were only 6 patients of the overall 41 that we had on the trial, so a small minority only who didn't achieve that very deep response.
Well, you've already teased a little bit about these results, so tell us, it sounds like they were pretty positive with these 3 powerful medications in this difficult to treat population.
Yes, indeed, we found tolerability to be very good. Response with very deep minimal residual disease was undetectable in the vast majority of patients. And at 3 years of follow-up, 80% of patients were free of disease progression or death, which is in that patient population a very promising result, I would say.
So the question that obviously arises, that this is great, you have 80%, but you had 20% who did progress. Now you've given them 3 great drugs. What do you do when they do progress? I mean, how are you managing those patients? Because it's going to be more as time goes on.
Absolutely, absolutely. However, the 20% who unfortunately didn't have that great outcome also included patients who had unrelated diseases. For instance, one patient, unfortunately so, died of ovarian cancer that in retrospect was pre-existing at enrollment but mistaken for big lymph nodes in the abdomen. So there are various reasons for that. Sure, there are treatment failures, and for these very few patients, retreatment becomes a question, but fortunately so, as you know, we have new development coming down the road with non-covalent BTK inhibitors, with bispecific antibodies, possibly with CAR T-cell therapy. So there is hope also for the very high-risk patients who fail these options.
So let me ask you this question. What is your sense of how much we should be doing? We're looking at doublets, we're looking at triplets, and we have very effective monotherapies too. We do add some toxicity, we certainly add expense, whether it's the patient paying it or the government's paying it. And I'm also just wondering about, what's going to be better? Is it all this stuff in parallel or sequencing? I'm sure you as a researcher thinking about your patients are thinking about this all the time. So how does this trial and how does your thought process go? Because this is throwing a lot at the disease early on.
Absolutely. This is sure an experimental approach at the moment. These triplet regimens are not licensed. What we have licensed in Europe now is the Ibrutinib plus Venetoclax doublet in the frontline in the relapse setting. Nevertheless, in the German CLL study group and in other study groups worldwide, we still do now head-to-head comparisons of continuous BTK inhibitor monotherapy versus fixed duration doublets, be it Obinutuzumab plus Venetoclax or BTK inhibitor plus Venetoclax, to really call out for who individually, which patient subgroup benefits from which treatment approach, because we need to personalize treatment even more, I think, in CLL.
This is really exciting, really important research. Any final thoughts or conclusions you want to share with the CLL patient community?
I think it's great times for us as physicians to live in these days. We develop, with the help of you and our patients, such new treatments that provide great hope and so much better outlooks. It is very important to keep on working hard on that, to do clinical trials, to do good translational research, to find new approaches that in the end will lead to cure of CLL and make this world a place free of that plague.
Dr. Stilgenbauer, thanks so much for what you're doing and what your colleagues are doing. I'm so grateful as a CLL patient myself. Thank you.
Always a pleasure. Thank you very much.